Good evening, ladies and gentlemen. My name is Dr. Markhan, and today we'll be conducting the second session of our AIMCAANA Monthly CME webinar meeting that we are having live. And we are joined on Zoom, as well as we are live streaming here on Facebook. And we will be talking about delirium, which is an epidemic within the pandemic that we are witnessing and noticing and going through these days. And briefly on the topic of delirium, of course, as we mentioned a little bit earlier, is a diagnosis that leads to significant morbidity and mortality in the medical setting. And sometimes it is overlooked. However, it is something that we should pay due attention to. And today our speaker is Dr. Ariba Khan. She is MD, MPH, and she works at the Aurora Health Center. And she is the adjunct associate professor at the University of Wisconsin School of Medicine and Public Health in Milwaukee, Wisconsin. I would like to have a disclosure for this meeting. And this is a statement for that this activity is a approved and accredited CME activity. And participants of this meeting need to watch this session in its entirety, as then you will be able to claim your credits. And okay. So let me share my screen. All right. So learners must complete an evaluation form to receive a certification of completion. Your chosen session must be attended in entirety and must attend the entire webinar, as partial credit is not available for this meeting. So this is designated as a live activity with a maximum of 1 AMA Category 1 credit for physicians. Physicians should claim only the credit commensurated with the extent of their participation with this activity. Having said this, we will continue with this meeting, and I welcome Dr. Ariba Khan to please take over, and we will start with the presentation. Dr. Ariba Khan, please. Thank you.
Assalamu alaikum. I'm just trying to share my screen. Just give me a minute. You can see my screen?
Yes, you can just pull up your the presentation, and I think we should be good.
It's online, so here it is. Okay. Okay. Assalamu alaikum. Thank you, Umar, for introducing me and inviting me, and thank you, AIMCAANA and Dr. Ghulam Abbas, for organizing this. I'm always very happy to participate in any events held by AIMCAANA. So it's my pleasure to be here. And thank you everyone for joining. The title of my talk today is The Epidemic Within the Pandemic, Delirium in Older Hospitalized Patients. I have no disclosures. There are 4 learning objectives for today's talk. The first one is understand the serious impact of COVID-19 pandemic on delirium in older adults, identify the risk factors for delirium during the pandemic, identify and diagnose delirium using telehealth, and implement strategies to manage and prevent delirium. I will start with the patient story. I'm a geriatrician, so I've been seeing a lot of delirium in COVID-19 patients. And I just picked this random case. One of my patients, my primary care patients, 83-year-old community dwelling lady who was brought to the ER by her family as she was more confused than usual. She had been declining and in cognition and function since start of COVID-19 in March. However, there was acute confusion and they brought her to the ER. She tested positive for COVID-19. She has a lot of medical problems, chronic kidney disease, mild dementia, hypertension, renal cancer, anemia. Functional status is that she needs help with her activities of daily living, and she walks slowly with a walker. Unfortunately, she did not have a good outcome. She passed away in the hospital, and that led me to research a little bit more about this delirium in COVID-19 and how we can improve the outcomes. So I will present what I learned. Delirium is a, I don't know, I just skipped, let me go back. So what is delirium? Delirium is an acute change in mentation, cognition, and thinking that develops rapidly, and it is reversible. However, in a number of patients, it may persist for several months, which is a big challenge. Delirium is also known as toxic encephalopathy, metabolic encephalopathy, and acute brain failure, depending on which specialty is seeing the patient. Delirium is different from dementia, as dementia is not reversible, and it is a chronic progressive disease. Delirium is a serious medical condition which has high mortality and morbidity in older persons. There is a lot of literature that describes these problems, both in the hospital and transitioning out of the hospital to home. So in the hospital, it is very common. It is associated with increased falls, higher length of stay, higher healthcare cost, and increased mortality. Unfortunately, despite all these problems that the patients with delirium face, it remains unrecognized and undiagnosed by healthcare workers. The key to delirium is prevention, because as one person develops it, there is no good FDA-approved treatment. There is also a high rate of depression or trauma, both in the healthcare workers, especially nurses, families, and patients associated with delirium. In the long term, there is limited literature, but the literature shows that there could be worsening of cognition, persistent delirium for several months, like up to 6 months. There's a decline in function, which may lead to increased family burden and caregiver burden. And they may need higher level of care like subacute rehab or nursing home. They have higher mortality, readmissions. Because delirium is underdiagnosed or maybe misdiagnosed as a mental health illness, there may be usage of inappropriate medications, such as quetiapine or Depakote, that patient may be discharged home with, and then they remain on those medications. I think it just skips very quickly. So now a little bit about the COVID-19 pandemic. I think we all know that it's caused by coronavirus. We are not sure, it has not been published as to who was the index case, but there was a BBC article reporting that the index case was a 70-year-old person in Wuhan, China, December 1st, and he had a known history of Alzheimer's disease. He lived close to the Hunan seafood market, like a few blocks, but he did not visit the market and his family was not sick. Subsequently, the cases of COVID-19 continued to increase, and WHO declared COVID-19 a pandemic on March 11th, 2020. So we will have the 1-year anniversary coming up soon. Initially, we just knew that it infects the upper respiratory and GI tracts. It binds to ACE receptors for cell entry. It causes hypoxia and could cause septic shock, multi-organ failure. As time went by, we also know that it affects multiple other organs. And now we know that it also causes liver failure, kidney failure, cardiac problems, myalgias, anosmia, a loss of taste, and then lastly, the headache and confusion that we are discussing right now. So COVID-19 and delirium is important in older people. Firstly, as you can see, this is CDC data. This shows from January 23rd, 2021, that about 14% of people above 65 years are infected by COVID-19. However, the mortality in this age group is much higher, 81%. So that's why it's important to know. And then secondly, present to the ER, 28% presented with delirium. So they may have the most common symptoms such as fever, cough, shortness of breath. However, we have to be aware that they may have atypical symptoms and they may just have delirium and not complain about anything else. So then we should test those people also. So that is why it is a serious disorder in older people. Now, next question is, how does delirium develop? What is the pathogenesis? And for delirium, the pathogenesis is believed, it's not clear, but it's believed to be either cholinergic excess or dopaminergic deficiency. So how does COVID-19 cause delirium? Before I go to that, so this slide came up, it's just shows that delirium is very common in severe COVID-19. So in this study, they looked at patients who had COVID-19 and ARDS, and delirium was there in 65% in the ICU patients. So it's very high. So then this is the etiology. Delirium has a multifactorial etiology. So the question is, how does COVID-19 fit in? And this model, I'll describe this model first. So this model is the most popular model, and it shows that if a person has a lot of risk factors, so a lot of predisposing factors, they are more vulnerable to have delirium. And a small insult can cause delirium. So for example, if there's a 90-year-old person who has dementia, multiple medical problems, and they are on a lot of medications, polypharmacy, then just urine infection can tip them over into delirium. However, at the bottom, you have a person who's not that sick. Maybe they're 66 years of age and they don't have dementia. So they are at low risk of developing delirium. So they need something really bad, like maybe septic shock to develop delirium. So this is the model. And so how does COVID fit in?
Are you on the meeting?
Well, I also wanted to say, like, if anyone has questions, they can use the chat function. So, or we could do it at the end or on the Facebook Live. So how does COVID-19 cause delirium? So it directly affects the brain, and it can cause delirium because it's a neurotoxic virus. So how can it get to the brain? So we know that it can go to the brain through the olfactory nerve, directly through olfactory nerve, and that's how people lose the sense of smell. It can also attach to the ACE2 receptor, which is here, and gain entry to the cell. It can cross the blood-brain barrier or just go through the blood into the brain. It is directly neurotoxic and can cause interleukin excess, and then also increase the permeability of the blood-brain barrier. So this is the summary. There are 5 mechanisms. So direct infection, hypoxia, ACE2, immune, and then the other thing. And then in the long term, it can cause cognitive and functional decline. And I like this, so I included this. It shows like there are so many different risk factors. So the person's risk factors, so age, comorbidities, and all that. And then COVID-19 inflammation affecting the lungs, the vascular system, neurological, and the hospital environment itself. And all of these will lead to decline in cognition and function. Are there any other ways that COVID-19 can cause delirium? So there are some unintentional effects of the COVID-19 pandemic. So indirectly, and we all know that there is increased isolation because of COVID-19. There is restrictions on staffing and restrictions on family being able to visit. Staff is spending less time in the patient's rooms to protect themselves. So patients are mostly in the rooms by themselves. So that I think we have not seen this kind of isolation ever in the past. This is the first time. And it has been a very big challenge for our patients and the staff and the families. Also, we are seeing a lot of staff members being sick. So there's less staffing. Now, our hospital has a help program, about which I'll discuss in the next few slides, which is a hospital elder life program. It is a prevention program which uses volunteers to prevent delirium. And now that program is not in place because the volunteers are not allowed to come to the hospital. So that's a big challenge. And then lastly, we are seeing also a lot of elder abuse because of isolation in the community and in the home. So it will, I think, move in. What about long-term effects? We know that COVID-19, people are suffering from long-term effects, and we also know that delirium can affect a person for a long time. So we will see decline in cognition, function, and the studies will come out regarding that. There is a few studies I saw about depression and PTSD, both for the family and the patients. This is a physician patient who described his time in isolation while he had COVID-19 and delirium, and he had a long length of stay. So this is, I just took one paragraph. He had like several pages. And this is how he described it. I was buried alive in the grave of an uncle of mine who died 10 years ago. I drowned in a pool that hospital nurses threw me into. I remember perfectly and clearly the feeling of lack of air, the constant feeling of dying. So that's a very scary experience to have. So this study I would like to describe, I think it's a very well done study, one of the first ones. It describes what happens to people who have COVID-19 and delirium. It was done in Brazil. So they have a 900-bed hospital. Brazil was hit quite badly, so they converted the whole hospital to COVID-19 patients. And they did a retrospective chart review. So that's one of the limitations. So they had 707 patients in the study time frame, which is March to May 2020. And their overall mortality was quite high, 39% in hospital mortality. And for their chart review, 1/3 screen positive for delirium. Only 12% were delirious on admission. So, and 30% total. So that means that those who were not delirious on admission, we could have prevented. So about 40% cases of delirium are preventable. So we could have prevented a lot of delirium in this situation. Now, patients who had dementia, 73% screen positive for delirium. And so they wanted to see what kind of outcomes these patients had who had both delirium and COVID-19. And their mean age is 66%, 57% are men, and only 4% dementia. So patients who had COVID-19 and delirium, they had more medical problems. They had higher mortality, 55%. They were more likely to have abnormal lab findings like high C-reactive protein, high D-dimer, lymphocytopenia, low albumin. Their main study aim was to describe the outcomes, and they looked at in-hospital death, which was higher, so 1.75% higher times higher if you had COVID-19 and delirium. Length of stay was higher, use of ventilator was higher, and admission to ICU was higher. Graph. So that means it's very serious to have delirium and COVID-19. This study I picked because they did a study to predict in-hospital mortality in older people who had COVID. And they used these 4 scoring systems. And I wanted to highlight that they didn't use delirium as one of the variables. So let's look at this study. It's a single center retrospective observational study. All the patients are COVID positive and they're above 65. And again, in the earlier part of the pandemic. These 4 scoring systems, I have never used them, but they're already like developed and people use them to predict mortality, but they wanted to see if it predicts mortality in their patient population. So overall mortality was high, 20%. And the mortality rate was associated with older age, worse radiological findings, higher Charlson comorbidity index, higher rate of dementia, renal disease, worse pulse ox, respiratory rate and heart rate, and abnormal lab test. However, it's a retrospective study, so they could not screen for delirium. And I think that's one of the shortcomings of the study. Their model did quite well, as you can see, and the area under the curve was quite good too, like 0.7 and higher for all of them. This is one of our studies. So we wanted to know what happened to the delirium rate over the pandemic. And the reason being that we know that delirium is under-recognized. So if it's under-recognized over time, we are doing a lot of education. So it should go up, the rate should go up if we are doing a good job educating people. However, COVID-19 directly affects the brain and can cause delirium. So that means that the delirium rate should go up higher during the pandemic. So what we did, we looked at data for past 2 years and compared the trend in delirium rate prior to and during pandemic in hospitalized patients above 65. So it's a retrospective study. So we are able to collect delirium data from the electronic health record, and it's called ACE, Acute Care for Acute Care Tracker. So ACE Tracker Snapshot. It collects data over the first 48 hours for people above 65. So it's only the first, so it's like a quality improvement electronic health record tool, and it gives you a snapshot of how the rate has been in the first 48 hours. And for the study purposes, we looked at delirium documented by staff nurses, and we have 14 hospitals in our healthcare system. So we used 2 time frames. One was longitudinal, so May 2018 to June 2020. And then we looked at 2019 versus 2020, but we only looked March through June because we got the data in August. So we didn't want any seasonal variation, and that's why we picked these dates. And so then we looked, so the overall median delirium rate was 6.8%. We had 70,000 encounters, and there were 42,000 patients. And the mean age was 78 years, mean length of stay was 6.5 days. So we looked at the delirium rate, and it increased by 2.1% over the time period, from 6.6% to 8.6%, which was statistically significant. But unfortunately, there was no statistical significant increase in, oh, where's my graph? Oh, here. Increase in the rate during the COVID-19 pandemic. It was as expected. So going back, so there were some limitations to our study. As you can see, the rate is quite low, and there are a lot of known limitations of data collection from the electronic health record, because it may be inaccurate or misdiagnosed data. However, because we are comparing over time on a monthly basis, that inaccuracy should be there for the whole time frame. So what we don't know either is we just studied the beginning of the pandemic, not the end part, or like not the, I guess it hasn't ended, but we need to get data for the rest of the pandemic. So we concluded that in our study, the delirium rate went up over the study time period. So we don't know why, but it went up. But the initial 4 months of the pandemic, it went up as expected, but not more than could be from the pandemic. So we need to get data for a longer time frame. So my next objective was delirium screening. So first objective was the serious impact. We talked about that. Second objective is identify risk factors. We did that. And third is identify and diagnose using telehealth. So there are a number of screening tests available. So anyone wants to write in the chat if they have used any of them, because I was not planning to talk about all of them. That would be like one whole talk. So DSM-5 is the gold standard. The most used is CAM and 3D CAM and CAM ICU, which is confusion assessment method. 480 is used more in UK. And DOS and NuDisk is used by nurses. So I will only discuss the CAM, because DSM-5, I find it hard to remember. The easiest one is SQUID, single question. It was studied in oncology patients. So simple question, you ask the patient, do you feel confused? Or something like, do you feel more confused than usual, than your baseline? And that's it. So that is better sensitivity and specificity than the nurses or the physicians. So if you ask the nurses versus physicians, patients are more accurate. So if you are not able to go into the room and you have only like a few minutes, that would be the question to ask. And then the next best would be confusion assessment method. So confusion assessment method has 4 components, and you need either 1 and 2 or 3 and 4. So first I'll just describe it, and then I'll describe how to do it quickly on the phone or video. So how we would do it if you are doing it in real, in person. So first one is acute onset and fluctuating course. Second is inattention. Third is disorganized thinking. 4 is level of consciousness. So for a confusion assessment method, you don't need any specific questions. You can use any memory testing like Minimental, MoCA, whatever is available to you, you can use that. Problem with that is that everyone would be using a different parameter and may not be agreeing with each other. So that reduces the inter-rater reliability. And when nurses perform it in the real world, it reduces the sensitivity and specificity. And also it's takes a long time. So just keep in mind these four things, and then I'll go to the next slide where as an easier version, it's called 3D CAM, the 3-minute diagnostic, 3-minute diagnostic confusion assessment method. I just put my picture up there because I presented at this conference in Australia and I taught them how to do it. So they thought it's 3D CAM in glorious Technicolor and uber short rapid ultra screen, old school versus fast and funky. So I don't think you can see it very clearly, but basically on the top here are the CAM features. And here are the questions. So how you would do it, if you do it in person, you'll ask all these questions. And then you'll see, like I have marked here, which ones are patient failed or they are positive. And then at the bottom, you need either 1 and 2, or either 3 and 4. So this person screened positive for delirium. Now, if you're not in the room, or suppose you're in the room, but you don't want to spend a lot of time, what you would do? You don't have to ask all the questions, because if one is positive, then the whole column is positive. So it's called ultra short 3D CAM. So you would ask orientation questions. Then you would, the hallmark of delirium is inattention. Then you would ask attention questions. So you could pick any of them. You could do name the days of the week backwards, or the months of the year backwards. And that would give you enough, because the number 1 is acute change. You would ask the nurse or family. Number 2 is attention, which is hallmark. So you could ask one attention question. And number 3 would be the orientation question. And number 4 would be level of consciousness. And you can see level of consciousness on the video, or you can ask the nurse. So that would be very important and quick screen for delirium. So that's the screening. Then the next was implement strategies to manage and prevent. So there are 2 strategies. One is pharmacological and non-pharmacological. And there's a difference between prevention and treatment. So first we'll talk about prevention. So prevention, there are a number of published and researched programs. And the one I mentioned earlier is a hospital elder life program that we use, HELP. I think it's copyright protected, and maybe it's not anymore, but it used to be. Oh, and CAM is also copyright protected, and MMSC and MOCA, they're all copyright protected. So HELP program. HELP program is a non-pharmacological intervention. It uses volunteers and elder life specialist, who's a nurse. Nurse goes to the bedside, screens the patients, and lets the volunteers know that patient qualifies for prevention of delirium. So they cannot have delirium, but they're high risk for delirium. Then they have these 5 things they do. So the volunteers do these 5 things: cognitive stimulation, early mobilization, sleep, hydration, and sensory impairment. Sensory impairment means they need to have their hearing aids or glasses. So that's HELP. NICE guidelines is UK guidelines. They are based on light nursing care. We don't use them, but I think we should. ABCDEF bundle is in the ICU. We don't have it, but also this is research-based and published. So now with the COVID-19, there's isolation, minimal contact, there's PPE, that is another barrier. And the patients with delirium take more staff time. Patients are up at night because of procedures or labs and such. So it's very hard to implement the prevention strategies, but at the same time, very important right now. So what can you do? So this is from the Vanderbilt University. So basically they said, like, keep doing what we were doing in the past. And the next slide will show how we can change things. So delirium screening, very important, like the way I just showed. Make sure the medications are screened by the pharmacist, that they are not on any inappropriate medications, beers, medications, antipsychotics, anticholinergics. Physical needs, so make sure they're not in pain, nausea, constipation, dehydration. Make sure call button is close by, phone is close by, cognitive stimulation, reorientations with each interaction. So having like a whiteboard, we have a whiteboard, it has the date, the who's the nurse, who's the CNA. And then they encourage family members to visit. So it depends on the hospital policy and how many cases we have. But if they cannot visit, then using telehealth or iPad or something to allow family to interact. Sleep-wake cycle is very important, like open the blinds in the morning, keep the room dark. So very simple things, melatonin if needed. You do not use like Ambien at night. Then mobilization, make sure they're walking in the room. Make sure that they have a chair in the room, but they're not laying in the bed all day. They have their cane or walker, and allow them to move in the room by themselves, which like our hospital doesn't allow. The bed alarm goes off. So that's not appropriate. Minimize like lines, like catheters. So because they'll fall otherwise, pulse ox, Foley catheter, reassess, like can you discontinue these things? Try not to use restraints. Sensory deprivation. So make sure they have their glasses, their hearing aids. We also have an amplifying device. If they forget their hearing aids at home or they lose them, then we have a voice amplifier. It's only $100. Okay, what can we do in addition? There's I wish I had brought it. There's a mask. It has like a little window, plastic window, so they can see your lips when you're talking. So I've used those for my patients. But of course, if it's COVID patient, you cannot use that. Then have a card with your name or photograph there. Orientation of like who is who, because patients feel very like lost. Having iPads, speak slowly, speak loudly, keep them mobile. So the physical therapist could give the activities to the patient can perform them. And the last one is for the intubated patients, they do this is part of the ABCDEF model. And then lastly, reviewing medications. That's very important to review every day. So that's prevention. Then next is treatment or prognostication. So that's part of the treatment, I guess. So palliative care. So right now it's difficult for us to do prognostication, but we kind of have an idea. It's an older person, they're hypoxic, they are delirious, they're unlikely to survive the COVID-19 infection. So, and then that's the patients who have COVID-19. And then the other aspect is if they do not have delirium, but they are end of life, I think 30% or more have agitation and delirium. So how to manage their symptoms of agitation so that the family is not like traumatized. Encourage family visits, educate the family and support, which is regular palliative care tools. Educate the staff and support them, and when needed, refer to hospice. So I only found very few studies about hospice, and this one I liked. The next is treatment. So treatment again is pharmacological and non-pharmacological. This slides, there's a little bit lag, but I just know my slides. So the non-pharmacological is very important. And that's the mainstay of treatment. So first of all, you treat the cause. You try to figure out there's something else, like do they have constipation? Do they have urinary retention? Anything else that's going on in addition to COVID-19 infection? And then most importantly, prevent any complications. If patient is agitated, they may fall, try to get out of bed. If patient has hypoactive delirium, they're laying in bed all day in isolation, they may develop pressure ulcers. Review medications every day. Make sure patient is comfortable and make sure that the function is addressed and they're not becoming dysfunctional by laying in bed all day. Avoiding high-risk medication. So I put some of them here. You can calculate the anticholinergic burden. If you just Google it, it just comes up and you'll be surprised that our patients have very high anticholinergic burden. Then so it's the same, pharmacological interventions. So they are not FDA approved, and they should not be used. However, we do use them. So first of all, Haldol has been used since, I don't know, 1970, I think, a long time. It does not reduce the severity. I think it reduces the severity, but not the duration of delirium. It doesn't improve outcomes, I think, except for like one study. So it's very controversial. And then there is extrapyramidal symptoms. And then we thought if we use the newer antipsychotics, maybe there'll be less extrapyramidal symptoms and less side effects, less effect like on heart and such. But that has not panned out. And we still continue to use Haldol. The rest, none of them are approved by FDA. Lorazepam, we don't use that because it converts hyperactive delirium to hypoactive delirium. You can use it for alcohol withdrawal. I found one study where they use plasma exchange, and I don't have any experience in that, but I know people use it for other things. That's pharmacological. And now I don't remember my next slide. So let me see. So in conclusion, common disorder in those infected with COVID-19. And delirium may be the presenting feature in COVID-19. Hence, delirium screening is essential in patients who have COVID-19. Non-pharmacological approaches preferred, but maybe to implement because of social COVID-19 isolation. So any questions? I'm open for any questions.
Thank you so much, Dr. Khan. Any questions from the participants? Do you prefer I unmute you and you can ask your question directly? I think Dr. Kamar. Okay, I think I'm going to unmute the participants so they can answer ask their questions. So, Dr. Ghulam Abbas, I think you can go ahead.
Thank you, Dr. Riba Khan. My question was, mostly elderly people have sleeping issues and they take some, those benzo or other sleep medicine. If somebody has sleep issues for chronic insomnia, so what will you recommend instead of Ambien? Thank you.
So like if they are taking Ambien or lorazepam, we should not stop it because they'll go into withdrawal. However, if they are not taking it and they have insomnia because they're in the hospital, Hospital Under Life program has one of the components or interventions is sleep. So what they do is if a person calls and says, I cannot sleep, they do not call the doctor. The nurse implements the intervention or the volunteer. We have a hard time finding third shift volunteers, so nurses implement it. But in the real program, it's the volunteers. So they do like a hand and foot massage, and they do a warm glass of milk and music. And then in our hospital, we also have lavender aromatherapy. But some people don't like it. So if they like it, they can have that too. And that has shown to like reduce delirium and help with sleep.
I don't like shake.
Okay, thank you. I'm going to have Dr. Kamar Abbas ask the next question if he's available.
Yeah, hi, Dr. Riba. Thank you so much for the presentation. So would you recommend any pharmacological therapy for hypoactive delirium?
So we don't do that because there aren't any studies that show that the antipsychotics or melatonin or donepezil reduces the severity or duration of delirium or improves outcomes. But I've seen like Vanderbilt, they have papers where they have described in the ICU, they use this one, zeprosidone. It has less D2 effect. So that means you'll have less extrapyramidal. But I don't know if they do it, but we don't do any pharmacological interventions.
Okay. Yeah, that ziprasidone comes in with Geodan name, right? I think the commercial name for that is Geodan.
Yes, yes.
Okay, thank you so much, sir.
Well, in the ICU, they also use a Precedex a lot. I didn't write that because we get a consult from them that patient was agitated. We gave Precedex and patient is now not waking up. So we get called because of side effects of Precedex, but it has very good data in delirium because they compare to lorazepam in ICU studies.
Mhm.
So lorazepam has worse, very bad outcomes, and Precedex is really much better than lorazepam. So you can be, let me think, like you can have like sedation, you can be in sedation, but you can wake up very quickly with Precedex. As opposed to lorazepam. So if an older person is getting lorazepam, they won't wake up for many days. But with Precedex, you are in deep sedation, but you can wake up quickly. So that has good data.
Yeah, thank you. Yeah, we do Precedex a lot. I'm one of the critical care attendings, so we use Precedex a lot. And also, sometime I'm not sure about the olanzapine. Olanzapine we use low dose 5 milligram or 10 milligram. That
We do-
helps.
okay, yeah. So I think our doses are lower because we don't prescribe in the ICU. So we use like 2.5 olanzapine. Haldol, we use 0.5 milligrams. So lower doses. And we use more olanzapine because I think it's just our practice pattern. I think Geodan is better, maybe. I mean, we use more quetiapine. We in our practice we use more quetiapine.
Okay, Dr. Hafiz Naeem, he if he's available, he can please unmute yourself and you can ask your question.
Hi, Dr. Riva. Thank you so much for a wonderful presentation. I just had a quick question because these COVID-19 patients, they're developing fevers in between and then they develop delirium-like symptoms. Before getting diagnosed with delirium, usually they are labeled as altered mental status and all the symptoms. So do you think all these patients should get a scan or imaging before they will be labeled as a delirium? Or do you think because of, just by going with the CAM scoring, we can safely say it's a delirium?
Yeah, we did look at imaging studies in our patients with delirium, and in our hospital, it was 40%. So I think that's too high. Only patients who should get the imaging studies are if they have some reason. And we did look at that, like if they were abnormal. So only, they were only abnormal. Imaging study was only abnormal if patient had fallen or the physician was suspecting like a subdural or subarachnoid hemorrhage because of something in the history. But if the history did not suggest anything, then the imaging study was negative. And other studies like at bigger institutions, they show that 30% of their patients get imaging studies. So since there is like nothing diagnostic on imaging, it's not recommended. Only time you can get like EEG, I get, like if you cannot differentiate between dementia and delirium, that's the only time I get EEG, and I let the neurologist know I'm not looking for seizures, I'm looking for delirium, and then they'll write like toxic encephalopathy, which means it's delirium. And so the only way would be to do the confusion assessment method, or in the ICU, like CAM ICU, would be diagnostic, or DSM-5, whichever diagnostic test you want to do.
Okay, wonderful. Just a quick question, one more. In terms of COVID-19 treatment, is there any change once the patient has a delirium as well?
So far, the only new thing I saw was the therapeutic plasma exchange, but I think like I wouldn't recommend that. And I think like we don't know right now. So we are just treating the causes like hypoxia, or whatever is going on, constipation, urine infection, and there hasn't been anything new.
Okay. Thank you so much.
Any further questions from the participants? Let me see if there are any questions on Facebook. Give me 1 minute. I think we are okay on Facebook. Okay. All right. So, okay, I have a question from Facebook by Dr. Saqib Sheikh. A great idea on volunteer involvement for better patient attention. How was this program conducted? Any specific volunteer required?
Yeah, so the volunteers at our institution and the original program, I think it was in 1996, so it's been around a long time. It's developed at Harvard. So basically, the volunteers, they get orientation, which is like their basic orientation. Then they have to be above 18 and they have to commit to 6 months, because the help orientation is quite long. I think it's like 20 hours or so. So they get training on how to work with the nursing staff and the patients, like early mobilization. So physical therapy or nursing will let them know this patient is okay to be out of the bed by themselves. So then they can go to that patient and make sure they are walking. They give them like food, water, they set up their meal tray if a patient has arthritis or cannot see. So that's nutrition, hydration. They bring like newspapers or magazines for them, or play like board games or card games with them. So that's cognitive therapy. And then the sleep protocol is for volunteers who are there at night. So we have a number of hospitals. So our hospital is close to a university. So we have a lot of students come from that university, and they are there 4 years, so they are able to participate. Other hospital, like in the suburbs, they have older volunteers, like in their 70s, and they do the hospital elder life program.
Okay. I have posted the link for to obtain your CME certificate in the chat box here in Zoom. So please do avail that. A second, Dr. Khan, can you also share your presentation if that is okay with you?
Yes, sure. So so you have it, right? You have the
I
link.
have the older version, I believe.
But it's on OneDrive, so it should be updated. But if not, I'll send you the new version.
Okay. Okay, sounds good. Sounds good. I can send
And
over.
anyone can use my presentation. It takes a long time to make a presentation, so it's good to use each other's presentations.
All right. Any further questions? If no, then Dr. Khan, thank you so much for your time and your knowledge. And we look forward to having you in the future as well. Any questions, anybody else? I think we're good for now. Thank you so much for participating in this activity. We will have another session next month as well. We will release the topic and the time as well. Please have any questions, please let me know. Otherwise, we will finish this activity now. You can follow this link that I have posted in the Zoom comment section, where you can obtain your CME certificate and credits. Thank you so much. Thank you everybody for joining. Thank you, Dr. Riba Khan. Thank you so much. Bye-bye.
Bye.